Check, check, check. Hello, hello, hello. Check. Hello.
Check. Good morning. Good morning. Mm.
Good morning, everyone. I would like to invite Dr. Prakash Moda and Dr. Umesh Srikanta sir to chair the session. First talk will be by Dr. Jitin Bajaj sir.
Good morning and welcome to this morning session on the final day of this wonderful conference. So there will be a slight change in the order uh, as we are waiting the speakers to come. Dr. Jitin Bajaj is going to be talking to us about peripheral neurectomy in spasticity secondary to spine injuries.
Thank you, respected chairpersons, Ashish Alok sir, for giving me the opportunity. So I'll be presenting on a neglected topic, spasticity for spinal injuries and other trauma, strokes. And often the neuromodulation, this botulinum toxin and baclofen pumps have gained over the simple and cost-effective and one-time procedures like peripheral neurectomy. So we should be stressing to these, particularly for a country like India. So after a weakness, which is spastic weakness after any trauma, the patient has several concerns to gain his power, to get relief from his excess spasticity, to get relief from pain. And he often asks whether the procedure you are advising is safe, whether it is durable in long term, and whether it is cost effective. So spasticity can be after trauma of brain or spine, depending upon the level. And it can also be after stroke, cerebral palsy, or multiple sclerosis. So we need to keep in mind that there are several options, particularly for generalized spasticity like cerebral palsy or multiple sclerosis, where we can advise a patient for intrathecal baclofen pump, which can be reversible. And we can also advise dorsal rhizotomy and rhizotomy, which are permanent and one-time procedures. Then for focal spasticity or even for hemiparetic spasticity or paraparetic spasticity, we can advise either Botox, which is again reversible and requires several settings, and then neurotomies, which I'll be talking about. So before embarking on the surgery, we need to properly examine and take history and differentiate whether it is a true spasticity or a movement disorder like rigidity, dystonia, whether it is a contracture, because if it's a contracture accompanying the spasticity, we need to relieve the contracture to have adequate benefit to the patient. And then we need to record according to the several charts of scoring systems for spasticity. Then we need to have videos of the patient in his spontaneous posture, different motions and angles. So the selective peripheral neurotomy, this procedure was introduced by Stoffel, which includes sectioning of about 2/3 of the fibers going to a muscle. And we need to select the muscle based on our prior clinical examination. So like you see in this figure, the branch which is going to the medial gastrocnemius is ultimately dividing into 3 peripheral branches. And we need to use the stimulator to determine which is the most harmful to of these branches, and then we can divide those. So the procedure can be used for lower limbs. For hip, we can go for obturator neurotomies. For knee, sciatic neurotomy. Foot and toes, tibial neurotomy. For extensor hallucis, anterior tibial neurotomies. We don't need all these neurotomies in every patient. For upper limb, pectoralis major and teres major for shoulder. I have never used for shoulder. The elbow and wrist and fingers, which is commonly required and complained by the patient. For elbow, we can go for musculocutaneous. And for wrist and fingers, we go for median and ulnar. So I'll be showing some of the examples. So this girl had an old D12 burst fracture with spastic paraparesis. And it was 2 years back when she suffered the trauma. So you can see she was in severe spasticity, and she could not place her foot flat. She had Achilles tendon contracture also, and every time, even on the bed, when anything touches on her foot, there was a spontaneous appearing of clonus. So she underwent bilateral tibial neurotomies and bilateral Achilles tendon tenotomy in the same sitting. And she had a very good benefit for his spasticity. And this procedure helped in the rehabilitation of the patient also. So the rehab is important after the procedure, as well as procedure helps in general rehab of the patient also. So another patient, this was a stroke patient of MCA stroke, and you can see spasticity in both his left upper limb and lower limb. And if you see closely, look upon the toes, there is appearance of inward deviation of toes as well as claw toes, which has become almost flat, and the foot as well as toes are also fat. And also, if you look again, the extension of toes has also appeared. And that is because of rebalancing of extensors and flexors after the division. Again, pre-op and post-op of the same patient. So the procedure is simple. This is left side, prone position, cranial, caudal, median, lateral. So we need to take care that the common femoral nerve comes from here, and we need to avoid dividing the common peroneal. Otherwise, the dorsiflexion of foot also goes away, which we do not require. So the procedure is just S-shaped to have cosmetic appearance. After the skin, superficial fascia, saphenous vein, then sural nerve also comes. We need to spare the sensory branches. Otherwise, there will be painful neuromas, etc. And here we can see the tibial main trunk, which is dividing into branches for medial and lateral gastrocnemius. So we are separating now this branch to this is medial gastrocnemius, that was lateral. And this is branch to the soleus. Then this might be the sensory branch. So all these things are confirmed by the motor stimulation. This is main trunk. And if you see, this is branch to the posterior tibial, which goes for inversion of the foot. So this is soleus. This is posterior tibial, as I said. These is branch to soleus again. This is a lateral gastrocnemius, sensory branch, and medial gastrocnemius. So tracing the medial gastrocnemius branch to its terminal level, we need to divide the peripheral nerves after stimulation. Take out about 2 to 3 millimeter of the nerve fiber. Otherwise, there can be regeneration. So you see, even with the use of scissors, the muscles are getting stimulated. And after the cutting, you see whether there is still remaining innervation or not. Then branch, this is to the lateral gastrocnemius. Opening the distal trunk. This is to the lateral gastrocnemius. Again, the same thing, stimulating all three branches and cutting two of them after confirming. We send it for research purposes, histopathological examination also. So this is for soleus. Sometimes you need to do fasciculotomies. If you cannot trace the nerve right up to the muscle, we can do fasciculotomies. This is soleus. And then we are opening a distal trunk. We are taking out the fascicles which go to the toes, great toe, other toes. And then we do it the same thing, stimulate and divide the 2/3 of branches to the 2/3 of nerve supply to the toes. And we can either suture the epineurium back or we can leave it as such. The procedure is rewarding. It has an immediate effect. Even in the post-op phase, we can see the result. These are the same pictures. I kept them, suppose video doesn't runs.
After having
For the upper limb, the incision for musculocutaneous is like this in the medial aspect of arm between the biceps and coracobrachialis. Similar to the oberlins, but little bit smaller.
also
And then we trace out the nerve between the biceps and brachialis, biceps and coracobrachialis.
here with
And then we can see the branch going to biceps, and then down below there will be branch to brachialis. We should be knowing that the biceps is supinator also. So for musculocutaneous, we need to divide more of brachialis nerve supply than biceps because we want supination. So in the next figure, we can see the branch to the biceps. For the median, we give incision between the antecubital fossa, like this. And then after incising the skin, superficial fascia, we need to go between the pronator teres and flexor carpi radialis. And when we open the lacertus fibrosus, we see the median nerve. The radial nerve will be a little bit laterally. So we need to again avoid cutting the radial nerve, otherwise the extension will be lost. So this is tracing distally median nerve after cutting the lacertus fibrosus, pronator teres, pronator longus, FDP, FDS, and flexor pollicis longus. So again, cutting all these may not be necessary in every case. We need to individualize the thing. And then behind the cubital, behind the forearm, in the medial side will be medial epicondyle, and the back will be olecranon fossa. We need to take out the ulnar nerve, and here we can do fasciculotomies. So again, patient of this is also a patient of stroke. We can see preoperative picture of the hand, and this is the post-op, immediate post-op, and we can see again relief of spasticity as well as some appearance of movements. Sometimes we need to bend the rod. Sometimes we need to put a longer C1 screw. Other pictures, pre-op and post-op of both lower limbs and upper limbs. So the procedure has long-term outcomes also. Even after 5 years, there is still about 50 to 60% of relief of spasticity, which we don't get with any of the medical things. We need to keep on giving Botox, and Botox has sometimes resistance also. Even baclofen pump, the drug also sometimes is not available in our country, apart from the cost. The procedure has some complications, like there will be paresthesia, dysesthesia lasting for 3 to 4 months, and we need to give pregabalin, gabapentin. In the long term, after 5 years, 6 years, there is some amount drop in the efficacy of 30-40%. Rarely paresthesia, very rarely. So this is an excellent option for relieving focal spasticity. Aim is to suppress the excess tone and achieve rebalancing. Intraoperative neuromonitoring is vital. We need to differentiate the dynamic movement disorders from the fixed ones, and this rehabilitation is critical. We have published this, please go through it. And we also invite you to the ISPNS conference next year in Jabalpur. Thank you.
Thank you so much, Dr. Jitin. Wonderful presentation. Actually, as you rightly started in the beginning, it is one of the neglected points and least performed procedures, but it gives a rewarding result. Any questions from the floor? Yes, sir.
Like in this, it was
The difference between the rhizotomy is being done for all the same thing, no? For this spasticity is different than the rhizotomy, or is the same result you get?
Sir, the result wise may be comparable, but in fact, in rhizotomy, we have to open the spinal canal, and we can have the side effects with that. I mean, CSF leaks, all those things. And then there is a risk of plegia. If we go too medial, doing rhizotomies, we have to enter the canal about 2-3 millimeters.
But
And if we go I mean, say trisotomy. For trisotomy, if we go too medial, we can have the plegia of the lower limbs. With the rhizotomies, again, of course, the plegia risk is not there. But that's also an excellent procedure for these generalized spasticity. For cerebral palsy, I mean, rhizotomy is a good procedure.
Yeah, but that can be done for this also, no?
Yes.
Rhizotomy. But they do selective actually, not the some of the rootlets. Not
We need
all
to
the
open the
rootlets.
canal. I
Yeah,
mean,
you have to open the
laminectomy or
canal
laminoplasty, something
and
has to be done.
So, but it gives similar results.
Yes,
Isn't it?
similar results.
We've seen that when we give antispastic treatment, a lot of these patients are able to support themselves because of the spasticity itself. And when we give antispastic drugs, many times they complain that they have developed more weakness. So how to assess that sort of they don't land up in a worse problem? Because if they develop weakness, they're still worse than what they were with spasticity.
Very nice question, sir. So firstly, this procedure only for advanced cases, the patients who are not getting relieved with adequate antispastic medicines. Then we need to do only for focal things. I mean, and enough 60 to 70% lysis only. We cannot go for 100% lysis of the nerve fibers. So there is some amount of residual tone by which the patient can support himself. And then we don't go for hip or knee. We go for ankle, as I showed, ankle, toes, and for upper limb for elbows and hands, so that he has tone for his standing and other functions. And then we can also mimic the efficacy preoperatively by injecting either perineural bupivacaine or his patient is affording in Botox also. So he can perceive that this will be the efficacy after the procedure.
And by any chance, can you know how much fibers exactly will be adequate to maintain the residual tone intraoperatively using this monitor?
It is generally 1/3 fibers which are generally supported. That are adequate.
You decide based on the thickness of the nerve. 1/3 you will leave behind.
Intraoperative stimulation we can get with this total, and after dividing 2/3, this will be the residual. So with intraoperative things.
But a lot of these are mixed nerves. So how do you sort of decide that you are, sparing the sensory just by stimulation, or there is an anatomic decision also depending on the lay of the fascicles in a particular nerve?
So it's very difficult to have anatomical knowledge of sensory and motor nerves. So basically it is stimulation only. So we trace out the nerve fibers. It's best to trace out the motor nerve fiber till the muscle itself and then divide. And the 1/3 fibers which are there, they will also be mixed. So that can support the sensory thing. And as I showed, we initially separated the sensory nerve which was going. There was significant improvement in AAD and BI was.
Thank you. Thank you so much.
There was also functional improvement on satisfied runner bleeding. I'll be going through a few cases from.
Yeah, now we invite Dr. Janmajay Jamdar and
Was reduced technique.
he will be speaking on transforaminal endoscopic surgery for lateral recess stenosis.
I am again grateful for this opportunity, sir. So let me start by saying that why I am saying lower zone stenosis, it is actually lateral recess stenosis, because our axis is different, so our anatomical classification needs to be different, so that we can understand our anatomy better and plan our surgery better. So objectives of this presentation will be mainly to how to decompress the lower zone, that is the lateral recess stenosis, under local anesthesia using a full endoscopic approach. I will also define the lower zone in brief, and our targets and the imaging of lower zone stenosis. So for transforaminal surgical purposes, we have classified the motion segment into three zones. So the upper zone is above the cranial end plate, the middle zone is the disc level, and the lower zone is below the caudal end plate mainly. So usually there is no change occurring between from the level of mid pedicle to the lower pedicle border, because there are no joints over there. It's mainly a completely bony canal at that level. So that is not much of our concern. So regarding the relevant anatomy for this procedure, usually significant pathology is seen mostly at L4-5 and sometimes at L3-4, rarely at L5S1, and very infrequently at L2-3 or above. There is frequently a small overhang of disc bulging into the lower zone, which I will show in my MRIs. And the roof of the lower zone will correspond with the lower pole of the facet joint. Our access via the transforaminal route is hindered by the superior pedicle and the superior articular process, and there is a very small superior vertebral notch here. And important thing is that it's a very vascular area, because of most of the venous drainage is coming out from this level. Is through where we access. So usually you have a lot of bleeding here. A very important thing to note is that the traversing nerve in the lower zone or in the lateral recess is fixed at ventral and lateral aspect, not so much by any ligaments, but because it is being wrapped around the pedicle and going outwards. So usually it is very difficult to mobilize the nerve in this zone. The lie of the facet, if the facet joints are coronal or sagittal, will dictate if and where the pathology will cause symptoms. The lie of the facet will also influence surgical access and visualization, so it will dictate how much of the superior articular process under surface you need to shave or trim before you can access that zone. And another important point is the axilla usually moves higher with respect to the disc from cranial to caudal lumbar level. So at S1, the S1 spinal nerve is usually taken off from the thecal sac above the S1, L5S1 disc space, whereas at L23 or L12, it will take off much lower, maybe just beside the pedicle. Another important thing is that the ligamentum flavum over the our targets and pathologies include the ligamentum flavum. Mainly, this is our chief target over the anterior and medial surface of the SAP or the medial facet line. Often a bulge of the annulus into the lower zone. Both of these come together to cause compression over there. We may also have synovial cysts, and the victim is usually the traversing nerve and maybe the cauda equina. The medial or inferior facet is only occasionally a cause of compression in such cases. So usually you need to decompress that the medial border of the SAP and the ligamentum flavum, which is underneath that inferior articular process. So the inferior articular process itself usually does not cause compression unless it's a case of non-lytic listhesis. In those cases, the inferior articular process can jut into the canal and then compress the traversing nerve. I'll skip this slide. I think we all know the anatomy of the ligamentum flavum. But with regards to transforaminal approach, Chow and others did a study and they found that usually there are three types. They classified the anatomy of the ligamentum flavum into three types. So type A is when the ligamentum flavum is only limited to the central canal and does not come into the foramen. Type B is when it comes into the foramen but does not traverse it completely. And type C is when the ligamentum flavum traverses the whole of the foramen. So there is a trend towards increasing foraminal encroachment of the ligamentum flavum with successively caudal. So at L4-5, L5S1, L3-4, you are more likely to find this sort of ligamentum flavum. With traditional approach, we usually remove the posterior ligamentum flavum near the midline mainly, which is usually not responsible for claudication symptoms, at least in initial cases where the patient has claudication in only one lower limb or not so much of cauda equina syndromes. So it might be possible that you end up not addressing the actual pathology in such cases, which is more lateral in the lateral recess. And traditional approach removes a large part of non-offending bone for access, which may lead to instability. Transforaminal access can decompress the lateral recess from ventral, lateral, as well as dorsal aspect, all 270 degrees around the nerve. So the basic principle of access to lower zone is we have to decompress the traversing nerve with and plus minus the cauda equina. The bevel has to be placed in the lateral epidural space, close to the caudal end plate of disc as possible, and as upward or as posterior as possible. So it has to be a very dorsal placement. It is not always possible if you have very big facets. Then usually your cannula is pushed forwards. In that case, you need to start there and then shave the SAP and come dorsal as you shave it. Skin entry will be slightly cranial so that your trajectory is caudal. And like I said yesterday, you don't try to make less than a 30-degree angle to the end plate to avoid damaging it. So I'll just describe the landing with this image. So you can see the needle has come from cranial and is facing, it is addressing caudally, and it has landed up in the lower disc space. Signs of adequate decompression are that you will have a free pulsation of the nerve or the thecal sac with the water column. You can see the filling and emptying of blood vessels on the nerve or the dura. Oozing will also start, and you might consider skipping dorsal decompression altogether if you feel that decompression is adequate. I will show just one representative case. So this was a 63-year-old male with severe left lower limb claudication for the last 6 months. S1 in the S1 dermatome, and he had no neurological deficit. So MRI shows there is a small synovial cyst over here in the left canal. And also I would like to bring your attention to this annular pouch over here. You can see that the annulus is not attached to the end plate as much as it is over here. So there is a small annulus pouch over here. And not so much in this case, but in usually cases with lateral recess stenosis, you will have a bigger pouch here. You can see this synovial cyst over here and very clearly compressing the nerve in the lateral recess. So this was the initial cannula placement. So again, this is a half in, half out. Half of my bevel is facing the epidural space. Half of it is inside the disc. Programs. So again, this is the initial view that we get. So as soon as I have decompressed a little bit of the disc, I will come out and start shaving the SAP, under surface of the SAP. And I need to shave it enough to be able to widen the superior vertebral notch. And from there, I can access the epidural space. So again, we're going in from the left side. So left side is cranial, right side is caudal. I'm also rotating the camera in between for the drilling. So this is the SAP. So we are drilling towards the base, especially because we need to target that lower zone, lateral recess. This is the medial anterior border of the superior articular process that I'm drilling now. And I'll start seeing the ligamentum flavum. So if it was a case with just ligamentum flavum causing nerve compression, I would just, it would look the same. I would see much more of the ligamentum flavum. So again, drilling the medial border of the SAP. And as soon as I've drilled it enough, the drill, I can feel a give into the canal. So this is the notch over here. This is the superior vertebral notch. And I need to be able to get my cannula inside that zone. So I have to drill in multiple directions. The ligamentum flavum now, it looks like a curtain which is preventing me from visualizing the canal. So I have just managed to get inside the canal. And so this was the first view of the traversing nerve now. So now I've inserted that instrument behind the vertebral body over there. I'm just getting rid of the ligamentum flavum, which is preventing visualization of that synovial cyst. This is the disc going, the annular pouch that we talked about. So I had to drill a little more. You can see the nerve is very much compressed. This is the synovial cyst now just visible. So my instrument is going into the roof of the of the canal. This is the dura, this is the synovial cyst over here. This is the dura. You can see that we can access that ligamentum flavum. In this case, it's the synovial cyst which is causing compression, but even if it was just the ligamentum flavum, we can get rid of it. You can see how much compressed the traversing nerve is, and now it has started pulsating well. Now the big chunk of the synovial cyst comes up. And this is in the roof, it's not under. So we can access a large part of the roof with our articulated instruments. So this was the final picture. Really pulsating nerve too. Thank you.
Thank you, Dr. Jamdar. Wonderful presentation. Is there any question from the audience?
For dorsal located, would you have still addressed it transforaminally, or you would have chosen
Usually
posterior?
synovial cysts will only they will only happen there where the facet joint is presented. They will not happen lower. So the facet joints will end at the level of the you can say at the mid pedicle border. So if you bisect the pedicle transversely, they will not occur below that because there is no facet joint over there. So they will always be above that line. Like I said, usually you will not find any pathology below where the facet joints end, because then it's a completely bony canal. They are all, you can address them all this way.
Thank you. Very.
In open, we know how much to sort of drill or cut the facet, or even in interlaminar, we get a vague idea how much to drill. How do you decide how much to drill the SAP when you are through the transforaminal approach?
So like I said yesterday, even if you drill off the whole of the SAP at the level of the disc, usually more than 2/3 of the SAP, which is articulating, will still remain. Because the most of the articulation, especially in degenerated diseases, has gone below the level of the disc. So the SAP rides up. You're mainly drilling the non-articular part of the SAP, the anterior and medial border. That is the most of your drilling happens there. You're not really disrupting the joint too much. You're even in open surgery, we say that you can take out half the joint or a third. So here we are actually disrupting even less than that.
But is there an end point?
So as long as if you're able to access your pathology, it means that your drilling is okay.
Enough.
Yeah.
Sir, how are the result long term? How long is your longest follow-up patient?
No, for this
For stenosis, which you are addressing, little traces stenosis,
stenosis
transforaminal.
is good. I mean, stenosis has good results because it's basically a compression. There is not much role of inflammation. So once you have taken care of the compression, usually the pathology doesn't return back. Patient may develop pathology on the other side, but that level is usually taken care of well.
Thank you. Now we invite Dr. Nishtha Yadav, Radiology of Spondyloarthropathy.
Morning, everyone. I'll be speaking on radiology of spondyloarthropathies. So the spondyloarthropathy can be divided into seronegative and seropositive. The seropositive one includes rheumatoid arthritis. The seronegative ones include ankylosing spondylitis, psoriasis, psoriatic arthritis, Ritter syndrome, enteropathic arthritis associated with the inflammatory bowel disease, and undifferentiated ones. So the majority of imaging features of seronegative spondyloarthritis are similar. So we'll start with the common one, that is ankylosing spondylitis. So it results in fusion of spine and SI joints, and usually more commonly seen in males. So we'll first come to the plain radiography. So this is a plain radiograph image of the SI joint, AP view, and the Ferguson or the oblique view. So this opens up the joint a bit more. So on plain radiograph, there's a modified New York criteria for grading of the involvement. So grade 0 is normal appearance of SI joint, that is regular appearance of the articular margins with no sclerosis or erosion. Grade 1 is some blurring of the joint margins, which is suspicious. Grade 2 is minimal sclerosis with some erosions. 3 is definite sclerosis with significant erosions with widening of the joint space. And grade 4 is ankylosis. So for bilateral pathology, grade 2 to 4 and unilateral pathology, grade 3 to 4 are considered as positive radiography for SI joint involvement. Now, we could see that especially in the early stage and in the grade 1, 2, it becomes very difficult to actually identify. So CT has an advantage that it is more specific, has a higher spatial resolutions, and the image can be reformatted in any plane. The disadvantage being that again, bone marrow edema, which is the first sign that that cannot be picked up on CT, and of course the radiation exposure. So this is the normal appearance of oblique view of the SI joint. This is SI joint with presence of erosions and sclerosis. So on CT, what we can see is these sort of erosions, sclerosis, and ankylosis. Coming to the MRI is most sensitive in picking up sacroiliitis, and first we see bone marrow edema. So, which is picked up on stir and post-contrast images. I'll be showing them. And inflammatory enhancement of the fibrous connective tissue can also be present. Later in the course, inflammation subsides and edema is replaced by fatty replacement. And in the final stage, there is sclerosis followed by joint fusion. So sclerosis appears hypointense on T1 and T2, and then fusion occurs. So like this is a radiograph in which we cannot really say that the radiograph is picking up any significant finding. However, the same patient's MRI, you can clearly see that there on stir image, there's presence of significant marrow edema on either side of SI joint on coronal and axial images. This is T1 weighted image, which is showing presence of marrow edema in form of T1 hypointensity and erosions. And post contrast, you can see this synovial enhancement, so synovitis. Again, axial stir image showing presence of marrow edema, post contrast showing synovial enhancement. T1 weighted image showing irregularity of the joint surface with erosions. Stir coronal showing marrow edema. And post contrast can also show enhancement of the surrounding connective tissue or enthesitis and osteitis of the area of attachment of ligaments and fibrous connective tissues. So in the next stage, the edema is replaced by fatty replacement, and this is known as tissue backfilling. So when the healing occurs, so there's fatty replacement within the SI joint. So this is the magnified image showing this is appearing hyperintense on T1. So this is known as backfilling. And then finally, the last stage is ankylosis, where we can see that the joints are fused. So these were the signs on involving the SI joint. Coming to spine, various radiographic signs have been described. We'll see them one by one. So this is the shiny corner sign, that is at the attachment of the anterior or posterior longitudinal ligament. You see that there is some sclerosis in the triangular corners of the vertebrae. This was the Romanus sign that has been described. Now then anterior corner erosions that we can see here, and again the shiny corner sign that you can see here. So these are the signs that you can pick up on radiograph. Then vertebral body squaring, presence of marginal syndesmophytes which show fusion. These marginal syndesmophytes on AP image, they show this sort of undulating appearance, giving rise to the bamboo spine appearance. And if you see that these syndesmophytes are quite different from the degenerative syndesmophytes. The syndesmophytes with inflammatory arthropathies are usually linear, thin, and give this sort of an appearance. On the other hand, the degenerative syndesmophytes, osteophytes are more coarse, they are more horizontally oriented, and this sort of an appearance is there. So then again on radiograph, you can see intradiscal calcification in later stages. Also ossification of the supraspinous ligament leads to this dagger sign, which we can see on this radiograph. And the fusion of the facet joints and the sclerosis and the ligamentous ossification gives rise to this trolley track appearance. So then another Anderson lesion. So it's known as a aseptic spondylodiscitis, which is usually seen in ankylosing spondylitis, and it has either an inflammatory etiology or it can be related to a stress fracture. So it's you can see that there is irregularity of the discs, vertebral end plates with sclerosis and inflammation with destruction of the disc. So this Anderson lesion can also present as an intradiscal or an intravertebral fracture, and sometimes the fracture can extend to the posterior elements also. So then eventually you can see that there's a long segment fusion of the vertebral bodies with extensive anterior and posterior syndesmophytes. Now coming to MRI changes, so in spine, the earliest inflammatory changes will again be inflammatory appearance of ligaments and their insertion, that is enthesitis, the site of insertion of tendons, ligaments, joint capsule or fascia to the bone. And the entities which can be seen on MRI are spondylitis, that is Romanus spondylitis, spondylodiscitis, that is Anderson's aseptic spondylodiscitis that we saw on radiograph also, arthritis of zygoapophyseal joint, and true ligament inflammatory involvement. So this is the radiograph correlate of Romanes sign can be seen here that there's hypointensity on T1 involving the corners of vertebrae, which are hyperintense on stir, and they also show post-contrast enhancement. So this is the attachment site of the anterior posterior longitudinal ligament and the syndesmophytes arising from that place. Then Anderson aseptic spondylodiscitis appears like there is inflammation involving the end plates, which is hypointense on T1, hyperintense on T2, hyperintense on T2 fat sat or stir image, and shows post-contrast enhancement. So in presence of other signs, like here we can see these shiny corners signs. So of spondyloarthropathy, if you see some imaging appearance like this, then that can be taken to be Anderson aseptic spondylodiscitis. Then arthritis of zygoepiphyseal joint. So you can see that there is marrow edema involving the facet joints along with post-contrast enhancement. Again, enhancement of the vertebral corners as well. Then costo-vertebral joint enhancement can be noted here, involving the posterior end of rib as well as vertebral body and the pedicles and lamina as well. Here you can see that there is marrow edema. This is post-contrast enhancement. Costo-transverse joint can also be involved. You can see that there is edema involving the joint as well as the rib and the transverse process. So true ligamentous inflammatory involvement, it can involve the supraspinous and the intraspinous ligament, as we see here. There's post-contrast enhancement of the supraspinous subluxation. There is narrowing of the zygoepiphyseal joint space as well. This is showing, and so anterior atlantodental interval more than 3 mm, posterior atlantodental interval less than 14 mm, and erosion of dens can be seen. There's also presence of subaxial subluxation here. The basilar invagination, in rheumatoid arthritis specifically, they are assessed using Redlin, Peterson method, and Renawat index, because McGregor's and McRae's line that we can see in this, they usually use reference as the tip of dens, so which gets eroded in rheumatoid arthritis. So that's why we use the other indices like Redlin, Journal, and Peterson method. This basically we draw a line similar to McGregor line, that is posterior end of the hard palate to the base of occiput, and then draw a perpendicular line up till the base of C2 midpoint. So this is more than 34 mm in males and 29 mm in females. If this becomes less, that is, there is upward subluxation of the dens, then it can be indicative of basilar invagination in rheumatoid arthritis. Similarly, in Renawat index, we draw a line between anterior and posterior arch of atlas, and then a perpendicular till the midpoint of pedicle of C2. So this is usually more than 15 mm in males and more than 13 mm in females. If this becomes less, that is when there is upward migration of the dens. So this can point towards presence of rheumatoid arthritis. So other features that can be seen as subaxial subluxation, fusion of, so you can see this is C3, C4. So subluxation, subaxial subluxation, fusion of the zygoepiphyseal joint, erosion of the spinous processes, Again, fusion and also destruction of the intervertebral disc space. On MR, the findings are similar to brain radiography. Additionally, you can see the soft tissue. So you can see the pan as well. You can see that the soft tissue is compressing the craniovertebral junction. Also, the signal changes of the cord can be made out. Like in this, you can see that there's T1 hypointense soft tissue, which is showing peripheral enhancement and the significant compression of craniovertebral junction. So cervicomedullary junction here as well, you can see, and also the signal changes can be made out on T2. In subaxial subluxation also, you can see myelomalastic change can be made out. So MRI has a better advantage in that. Also, you can see basilar invagination and joint fusion here. Psoriatic and Reiter syndrome have similar features. In addition, they have radiographic manifestations of small bones of hand and feet. Specifically, Reiter's involves calcaneum more commonly. So you can see some
Ma'am,
fluffy
can you
periods.
summarize, please?
Yes. Then there is some paravertebral ossification. Just very shortly about the mimics, there's degenerative changes involving the SI joint. Spondylodiscitis, infective spondylodiscitis will have this granulation tissue. This is inflammatory involvement of the SI joint, infective. This is DISH, diffuse idiopathic hyperostosis. This is sacral insufficiency fracture in which the marrow edema is confined to the sacrum and not involving the side, and you can see the fracture line. This is osteitis condensis ileae. This is postpartum bone marrow edema, which gets resolved in follow-up imaging. These are just some anatomical variants of SI joints. Thank you.
Thank you so much, Dr. Yadav. So it was very detailed, very exhaustive. Unfortunately, we have to stick to time. That is why. Thank you so much. Are there any questions? So may I ask one thing? So means many times we see those small paradiscal changes in Angst-Pond cases who come with back pain.
Yes.
Is there any radiological criteria where you can predict which of these is going to progress into a full-blown Anderson lesion with instability? Do you have any radiological criteria where you can say, okay,
No, sir, but once an Anderson lesion is identified, so basically the difficulty happens whether or not it is infective. So if you have other features of spondyloarthropathy, like if you're able to identify these shiny corner sign, or the patient has other features like sacroiliitis and all, and you're getting a spondylodiscitis, then you can be more sure that this is an aseptic process. It's not an infective process. And so you have to treat it accordingly, just either with conservative management or stability of the spine. But so the main differentiation that we have to make is that whether or not this is an infective like tuberculous spondylodiscitis or a pyogenic one. So usually if you can identify other changes of spondyloarthropathy, then you can be more sure of it being an Anderson lesion rather than infective process.
Thank you.
Just to, in our practice, more of the times, at least myself, I'm not using the Ferguson view.
Yes.
So what is the sensitivity specificity between AP and the oblique? So is it a must to get a Ferguson view? Or?
No, sir, not much. Actually, the radiograph itself, unfortunately, because MRI is not so widely available or because of the cost issue, but otherwise the sensitivity of radiograph per se is very less. So it will be 30%. The changes will happen later in the stage of the disease. So early stage, you're anyways not going to pick up. So if possible, an MRI is always good. Sometimes the oblique view can help in picking up subtle erosive changes, but those changes again have to be confirmed on other imaging. So these were mostly at that time when MRI was not that widely available. That time these sort of views were more in use.
Thank you so much. Maybe there is again slight change in the order of talks. Maybe call upon now Dr. Amitesh Dubey. He's going to be talking to us on microendoscopic discectomy.
talk about the systems that I use and the way I'm doing it. So let's start with microendoscopic discectomy technique. It was introduced. So microdiscectomy was introduced in 1977. We all know by Dr. Yasser and Dr. Kasper. And then simultaneously during the same era, percutaneous discectomies using with the transforaminal approach was also started. And microendoscopic technique was introduced by Foley and Smith in 1997, not long ago. So the tubular retractor, this was used in bimanual fashion using standard microsurgical instruments without continuous irrigation. So in endoscopic techniques that was used, we need continuous irrigation, and there was separate sort of separate finer instruments. Here we use standard microsurgical instruments, and there is no need of continuous irrigation. An interlaminar approach is used. So I will discuss about two systems that I have used. So Distendu endospine system that I initially started with this system, and then recently I have switched to EasyGo system. So both these systems are very good systems. There are drawbacks, benefits and drawbacks in both the systems. So Distendu system, it has one outer set of outer tube. So this is the outer tube with the trocar, and the inner tube with an endoscope. So this is the inner tube, and this has one attachment for the endoscope. The endoscope, the telescope used is 18 centimeter long. The same which is used in many surgeries, and even in ENT or uroscopy, it is 18 centimeter long, 4 mm in width and diameter, and 0-degree endoscope. So the outer tube is elliptical in shape, and inner tube, it fits tightly into the outer tube. And there are like 4 channels in the inner tube. One larger channel is 8 mm size for the instruments like Kerrison punch or disc forceps or the endoscopic bipolar if you're using it. One 4 mm for suction cannula, one 4 mm for telescope, and one for nerve root retractor. So there are 4 channels here. So this is the broader view. This is the inner tube, and this is the outer tube with the trocar. So what you do, you give one paramedian 1 to 1.5 centimeter from the midline, one small incision, then you dissect it, and you give incision into the fascia. You detach the muscle using sharp and blunt dissection, and then you just push this outer sheath with the trocar into the inside and dock it into the lamina. And then you insert this inner tube. So this is the system. Once you insert it, so you see this is the inner tube, you have inserted it. And here you need both your instrument inside. So this is the suction. This is one other instrument, could be Kerrison punch, and you have to balance it. Since it is a dynamic system, so it keeps on moving with your movement. And one of the drawback that I found with this system is that you cannot put both the instruments together inside. Since there is a 12-degree angle between the larger instrument from where you insert your instrument and the endoscope and this suction cannula. So once you've put it inside your suction, then you have to remove the suction and then simultaneously insert your other instrument, whatever you're using. And one more disadvantage that I found is that this whole weight of all the system and the camera had it into your head. So during long surgeries, I've found it that I get tired easily with this system. So this is where you dock. So half and half, you have to be half over the lower part of the lamina and half into the interlaminar space. So basic surgical technique, the basic surgical thing that you do in microendoscopic discectomy is similar to what you do in microdiscectomies. These are the set of instruments. One very important thing is accurate marking of the level and the direction. So this system was developed by Dr. Jean Distendu, and he have always in his presentation said that you have to be in the direction of the disc space. So you see it's slightly towards the caudal side, the skin, and you have to keep the direction of your system parallel to the direction of the disc space. So I'm just representing one case of 30-year-old female with right L5 radiculopathy. So this will be a right-sided approach. Right-sided approach is a little challenging for all of us who are right-handed because everything is like inverted. So you see there is a large L4, L5 disc. Here I'm just separating the muscle tissue, soft tissue from the lamina. Then this is laminectomy. You have to do laminectomy till the ligamentum flavum is detached. And one extruded part of the disc is present that is being removed. So once you do a little decompression, then you can retract the nerve root and do further decompression and further removal of the disc from the disc space. And if needed, you can use a small knife, 11 number blade, and do further extend the annular breach and then complete your discectomy. And wash it off with amount of saline. So this is another system, the EasyGo system. We have here we have serial dilators. There's an outer sheath or trocar which is of various size from 15 mm diameter to 19 and 23 mm diameter, and there is a holder. You can see the scope that is used is turned to the 90 degrees, so it does not come into the view and does not obstruct the view. And it is slightly slanted and 25 degree. So these are the serial dilators, and these are the serial systems that you use. This is a small 5 centimeter, 7 centimeter, and 9 centimeter with various diameters. And this is how it is attached to this articulate system. And so it is a stable system. You use normally you with microsurgical instrument, these bipolars that you use in the neurosurgery that can be used. Only thing is it has to be a little longer. And there is no collision. There is no weight on your hand, and you can do bimanual dissection if you need. So this is another case. This 36-year-old male with severe bilateral lower limb radiculopathy, right was more than left, right EHL weakness was present, and there was bladder involvement also, and perianal numbness was also present. So you can see there's a large L4-5 disc. The L5 was slightly sacralized, and this is the axial view. You can hardly see anything. This is critical stenosis. So I use the right-sided approach again. And you can see the system is stable. In last video, the whole system was moving. This is stable. There's no weight on your hand. And you can put two instruments, even sometimes if needed, you can give one instrument to your assistant and you can do the surgery. Here I'm working on the axilla. So whenever I'm working at the axilla, I found that the bleeding is little more than expected. And once it is slightly decompressed, you can use these patties to retract the nerve roots and complete your surgery. Extension of the annular tear. And removal of the remaining disc. Here, what I'm doing is I'm using a angulated instrument, and I'm pushing the extruded disc, the prolapsed disc inside the disc space, and then I'm taking it out from inside the disc space. You can see the nerve root is totally relaxed. And there's because of my teacher, Dr. Y.R. Yadav sir, one paper was published a few years back, our experience with 920 patients. And this is just small video where I wanted to show conjoined nerve roots. We all know that approximately 5 to 6% people, it can be normally present. But when you do a surgery, then sometimes it becomes difficult to identify it, and you may end up injuring the nerve root. So here you can see the two nerve roots are present on the same level, and when traced upwards, they were arising from the same sheath. So this was very well seen with the help of endoscope. This rising from the same sheath. So with microdiscectomy and microendoscopic discectomy, So MED is also well accepted, valid and safe and similar result. It is not that we have got better result with the microendoscopic discectomy. It is same as what we get with microdiscectomy. But what I have found that the vision is slightly broader, better, and the anatomy is better seen with microendoscopic systems. The viewing angle, all those systems, all those things are better, especially if I am doing LCS and I have to go to the opposite side. Then also I have found that this system is better than microdiscectomy. I do both microdiscectomies using tubes and these. And the viewing is better with microendoscopic system. And it is minimal invasive, small size if you're using like 15 mm or 19 mm, 1.5. Most of my incisions are 1.5 centimeter, less post-operative pain. The earliest discharge patient can be discharged on the next day, mobilized on the same day, discharged on the next day. And there are many things that I have been doing with this system, like lumbar canal stenosis, lateral recess stenosis, even cervical discectomies, and also a few cases of small size intradural extramedullary tumors extending to 1 or 2 level that can be done with this system. So it is safe, effective alternative to microdiscectomy, and we can get a little better visualization, broader view. Thank you very much.
Thank you, Dr. Amitesh Dubey. So any questions from the audience for him? So which system do you like more? You have used you told us you have used tubes, you have used Destendo, you have used EasyGo. So what is your choice? How do you select in a particular case? Now, like tomorrow
No,
a
I
case.
have stopped doing Destendo. I'm using EasyGo.
Okay.
And if I have option of choosing between tubes and EasyGo, then I choose Easy because of better vision.
Okay. Okay. Thank you. Thank you so much. So maybe now call upon the next speaker, Dr. Sumit Pawar, and he is going to be talking to us on PSLD, understanding the instrument.
Good morning, chairpersons, and good morning, all the delegates. It was an excellent lecture. It was a very important lecture, according to me, for this conference, that we all need to know the basics of tubular EasyGo system, Descendo system. That technique is the workhorse of all MIS techniques. And then, if you want, you may go ahead with the fully endoscopic systems. This can be optional in your career. That is not optional. So I think you should focus all your energies in learning the tubular system first, and then you can go for endoscopic systems. Now, the endoscopic system problem that we have is we don't have the know-how of what is required to start your first case and what is required from your side and from the OT's side that needs to be available. I've just tried to make a lecture comprising of all the instruments that you might require for an endoscopic system. This is about PSLD. And I've tried to cover other things as well. So instruments in endoscopy can be, this is a typical trolley of an endoscopic surgery, which has a lot of extensive machinery used for different purposes. You need the endoscopes, you need the instruments to be going through the endoscopes, and you need supporting equipment along with that. Endoscopes I've discussed yesterday can be divided as per based on the trajectory of the instrument or whether it is going through the working channel. So what we just heard from the previous speaker were all endoscopy assisted techniques, the Destando, EasyGo system, and also UBE. So all your existing spine instruments, the dissectors, disc forceps, punches that you have in your OT for your open cases or microlumbar discectomy cases can be used in these cases as well. It is better if you have them bayonet shaped, but it's not a mandatory thing. It is better, but definitely not mandatory. Whereas fully endoscopic, all punches, every single instrument is totally unique. They are separated. You cannot repeat them for any other surgery except for this surgery only, and they marry that endoscope particular technique only, usually. About the endoscopes, these are a few things that you need to know. The working length, whether it is, it matters whether it is an interlaminar technique or transforaminal technique. the outer diameter and the inner diameter of your endoscope, angle of endoscopic view, 0, 10, 12, 15, 30 degree, a lot. Many companies have come up in the market. There are Chinese scopes, there are German scopes, and every company has their own angulation, and every angulation has its own benefit and its own drawback as well at the same time. You need to choose only one of them. You need not change your, I'll use 30 today and I'll use 0 today for, especially for interlaminar approaches. So you can see these are the typical endoscope that you use for the transforaminal, and this is for the interlaminar technique. The transforaminal endoscopes are usually, you can see, significantly longer, almost 20 centimeters as compared to the interlaminar scopes. So these are the two lengths. The entire length end to end is the full length of the endoscope, and this is called the working length of the endoscope from the point beyond which you're going to be inserting in the working channel. The big difference over here is all your instruments that you're going to buy afterwards have to be longer than the end-to-end length of your scope. The inner, this is the cross section of this endoscope itself. The larger aperture over here is a working channel. Every single instrument that you're going to be buying for this endoscope, or if you're going to be buying for this endoscope, has to be less than the inner diameter of the endoscope. The remaining ports can be, you can have 2 ports or single port for irrigation and suction. And the black hole that you can see over there is the viewing the lens over there. So this is a typical endoscope that I use. I need to know the entire kundali of my endoscope, because initially, many cases, even you yourself have to wash your instruments to take care of them, to get a feel of the endoscope. The endoscope should be an extension of your arm and not something totally separate that's coming inside. So what I have has a 5.5 millimeter working channel. Why have I chosen this endoscope, which has an outer diameter of 8.5 and an inner diameter of 5.5? It varies. The most common endoscopes today in India right now, we have the 1 centimeter outer diameter and 6 millimeter working channel. The benefit is that you can put bigger instruments inside. They're more sturdy. They don't break easily. But then you need a 1 centimeter outer diameter. So it is significantly bigger to put inside the spinal canal while doing decompression. So when you are retracting the nerve root and trying to do discectomy, the 1 centimeter outer diameter sheath also can cause some neuropraxic injury on the nerve root due to traction. A smaller scope in that case would be better, but a smaller scope means again smaller and flimsy instruments. So you have to have your own cutoff, what is going to be suitable for your case and your practice. And of course, the person who has taught you, your teacher, your mentor, he will be the best person to guide you the pros and cons of whichever system you're going to be buying. These are the just different variations. I had made one point yesterday, which I like to repeat, that these three always marry each other. The dilator, the working channel, and the endoscope, they always go hand in hand. There is a hardly 0.5 to 1 millimeter difference in the outer diameter, inner diameter of these tubes. So you cannot put this scope through this dilator if they are not of the same configuration. And you will have to do it completely separately. So we have covered the endoscope, the visualization, and light source. The light source is the same one that you are using in anyone in your hospital is using. Same light source works over here also. You can have Castros, Stryker, Olympus, any company. They all are compatible with every single endoscope. It never changes. So this endoscope over here, and this is universal for all the scopes, that this you can remove this adapters over here so that every company fits to your endoscope. Same for the camera also. The camera and the light source are common. If your hospital has arthroscopy or ENT surgeon is doing sinoscopy or any basic endoscopic surgery is happening, laparoscopy is happening, you are ready for endoscopic surgery. Now it is a matter whether it's a 4-chip, 4K camera hai, 3-chip camera hai, what HD monitor you have or a 4K monitor. It's just a matter of plus or minus, better visualization, nothing else. But you can see. This is the set of instrument that we use for PSLD. A very, very basic set is used. 5 to 6 instruments are there which need to be used over here. So this is the endoscopic, the endostick 5.5 millimeter working channel. This is just a representative image. Every single set is going to be almost the same. You have a dilator which is 7.9 millimeter, a working sleeve of 8.5 inner diameter, which fits the endoscope, goes inside that. You will have Carrison punches, 40-degree upward angulated, 2, 3, 4, 5 millimeter, a dissector, which is a long instrument used for teasing the tissue, a tactile hook. What all instruments that you are used to normally, a number 4 Penfield का ही ये dissector है. Your right angled tip का ही ये tactile hook बना हुआ है. And your disc forceps is the grasping forceps. Length is longer, the diameter of the instrument is smaller, which is what makes a difference. The working sleeve is this is a standard working sleeve. You can have different kinds of cuts in the front based on the use that you're going to be using it for at that point of time. Most commonly, all of us mostly have a 30 to 45-degree angulated working sleeve. These kind of sleeves can be good if you want to retract the nerve root and work on the facet or the lateral part. These are the different type of grasping forceps. You can note it with your eyes itself. They are very, very flimsy instruments. These are the most common to break and the most expensive in buying the new instruments. They can have different cups, which serrated, non-serrated cups, and which can ease out the removal of the tissue. They can be bent, they can be curved at this end also, they can be upward angulated, and a lot of variations are available for that. These are the standard punches that you will be requiring. Different companies have different sizes of it. 2, 3, 4 are the most common that we use. One of the companies has only 5.5 millimeter, and which is a pretty big punch. And this usually can be cross used in most of the cases. Don't try to use the transforaminal punch for an interlaminar case. The length of the instrument is so big. When you're doing TF, you're holding like this. Same when you're trying to use the interlaminar technique, you're going to have your shoulder pain, and you're with your lead apron and all, it's going to be a bit troublesome for you. And you tend to bend the instrument in that case, instead of bending the endoscope. So these are the essential things that you require, without which you cannot start your case. Now, this is the additional, the flare instruments, which will make your job easier. The drill system. I started doing endoscopy 2019, and I got the drill last year. Till then, didn't have a drill, and life was going on. Different type of drills and sheets and covers can be used. These are in two kinds. One can be a proper shaver system, which has a very low RPM, a good torque, which just shave off the bone. And they make it easier because underwater you're going to be using this drill system. So they do your job significantly easier. We have recently developed our own very high RPM motors as well, which make your job faster. But you have to safeguard it. You have to be very sure you're not plunging inside, because of the long length of the instruments, there is a risk of you not having a good control. If you have a cheaper instruments, they will wobble a lot, and you have to safeguard there should not significant wobbling, because you're moving in a very, very small area. You must remember that, and very critical area as well. You can have different types of the tips can be different. You can round, the conical shape is there. You can have the complete hooded, so that you don't injure the dura. These are very essential and good instruments when you're doing the undercutting of the base of the spinous process. These lateral sleeves can be very important when you're drilling the lateral part of the middle part of the facet along the nerve root. This is the Indian drill that we use. It has everything, and we can have different systems attached to it, and not very, very expensive. Different type of drill heads that we use. Manual drills can be used. They're especially important in transforaminal surgery, not in interlaminar cases. And they help in achieving the similar things for foraminoplasty. What you cannot do with the drill, manual drills can do it. Radio frequency coagulation is very, very important. Without radio frequency probes, it is very difficult to do your endoscopic surgery. It can be done with a bipolar and a cortex system, but really, really not. The benefit of endoscopic is radio frequency. When you're using radio frequency coagulation, the heat production is about 47 degrees Celsius. It's not burning and charring the tissue. So at 47 degrees Celsius, you can very, very easily use it close to the nerve roots. You can use it on the dural sheath, you can on the dural sac. You can use it on the nerve as well at a very short current for a very limited duration. You can use it. It's not like you're putting a bipolar that you're using for daily basis on a nerve root. So because of the temperature that is so low and underwater, it becomes a bit easier to use the radio frequency coagulation. The high frequency makes it possible. The plasma is even better than this. The temperature increase is significantly lower. These are the different uh, tips that we get, which will, the bigger head is makes it very easy for you to dissect the muscle, and the finer tip over here makes it very easy to coagulate the epidural veins inside. These videos, I think you have seen. This is just my first case that I had done, and not a very beautiful case to see, because you can't see anything. Even I could not see anything that time. But I always show this video to show that you can be lost and it's okay. Perseverance. Some tips I've told yesterday. 4 hours it took me for a single L4, L5 discectomy. Whether it's justified or not is very difficult to say. But patient is, in the end, was completely pain-free. So we have achieved our surgical endpoint. You can see the ligamentum right over here. You can see the color appreciation, the yellow ligament over here. And it takes some time. And this is a very refined case that, again, I had shown yesterday. Much significantly later, this is the full sheath is used to retract the dural sac and the nerve, and we can very happily and safely do the discectomy. And patient has very good recovery after that. Thank you so much. This is the this is your, you have to be the Iron Man of your OT. This is how the open surgeons are going to destroy everything, the facet, the stability, the ligaments, the supraspinous, everything can be destroyed. But when you have to save the beautiful nerve roots, the beautiful stability, and the important structures around it, you have to be selective, you have to be calculative, you have to take your time and target exactly the pathology and not the normalcy. And then, only then, you can save everything and destroy the bad things. Thank you so much.
Thank you, Dr. Sumit.
Thank you, sir.
Thank you. Thank you for that wonderful talk. Any questions for him? Yes.
No. Yes. It's done by many surgeons to shift the scope to a smaller scope. It helps in, without too much retracting, you can do it. I never found the need for it. So, do it. Thank you. Thank you.
Thank you.
Thank you, speakers and chairpersons. I request Dr. Umesh Srikanta to please felicitate Dr. Amitesh Dubey. I request Dr. Prakash Moda to please felicitate Dr. Nishtha Yadav. Thank you, chairpersons. You can join for tea. It is being served at the exhibition area. Thank you. Then we will start the next session after 15 minutes. For the next session, I request Dr. S.K. Sherikar and Dr. Rajneesh Kashara sir to chair the session.
We start with the last session of this meeting, important meeting, a very excellently arranged meeting. And we call upon the first speaker, Dr. Mayuresh Hinduja. He will be speaking on the spinal nerve blocks. Dr. Mayuresh.
Good morning, everyone. I will be talking about spinal nerve blocks. Yesterday, we had a very wonderful session by Dr. Ashish sir. So I will not be covering whatever things have been covered, and I will be covering only things which he could not cover because short of time. So it was discussed that it has both diagnostic as well as therapeutic value. These are the commonly used blocks which were discussed yesterday: transforaminal, selective nerve root. Erector spiny block was demonstrated yesterday how it is to be given. Facetal block, medial branch block, caudal epidural block, SI joint block, ganglion impulse block. And cervical interlaminar block was also discussed yesterday. So I will be mainly focusing on transforaminal lumbar epidural block, median branch block, and ganglion impulse block. So there are three types of lumbar epidural block: transforaminal, paramedian interlaminar, or midline interlaminar block. So we should prefer transforaminal block over interlaminar block because it has better results. The pathology is anterior. If the disc is anterior, annular tear which will be lying anterior. And if it is because of chemical neuritis, the pathology is anterior. So better drug should be delivered anteriorly. And it has lower complications, better results. And the root is also lying anteriorly. So it has always better results than interlaminar approach. Moreover, all of us who want to start transforaminal discectomy should start with transforaminal blocks. You should give maximum transforaminal blocks so that you are well versed with transforaminal blocks, your needle reaching up to the disc and epidural space. So the indications of transforaminal block are disc herniations, radicular pain. It is not a good case of to give transforaminal block in case of myelopathy, a motor deficit, or a bladder bowel involvement. So coming to the technique of transforaminal epidural block. So basically, it was initially described that we should make 4 lines. There are many techniques to reach epidural space. There are fixed distances also, like 9 millimeter, 12.5 millimeter, 12.5 centimeter from midline for different levels. But each patient is having different anatomy. So either you calculate it on MRI or you make intra-op lines. This is the best technique. You make intra-op lines, and it will depend if the patient is obese, 110 kgs, then 12.5 centimeters will not work. So we should proceed with the first line, AP line, midline marking, then second line, AP line, disc level marking. Then third line will be the lateral view, in which lateral skin marking is done. And then the fourth step is needle entry point. So this will work for all patients, irrespective whether it is a very lean and thin patient or a very obese patient. So this is the first line. It should be true AP view. Like we see in the upper C-arm image, it is not true AP view. The spinous process and the both pedicles. The spinous process should be equidistant from both the pedicles. In this image, we see the spinous process is near to the left side of pedicle. So it is not an true AP view. It is an oblique view, and it will cause incorrect needle placement. So the bottom image is showing a true AP view and midline marking of the rod. Second line will be AP view, in which we have to mark the disc level marking. So we have to mark the disc level. We have to keep the rod from center, and we have to see whether it is coming above the iliac crest or below the iliac crest. Then we have to take a true lateral view. In this image, we see in the second image, it looks like that we are at the L4, L5 level, but it is not a true AP view. A true lateral view, when we take a true lateral view, we see that we are at the body, at the level of body, not at the level of disc. So it should be true lateral view, and then we should place the rod. The anterior end of the rod should be at the level of anterior annulus or antevertebral body. Then we have to mark a lateral skin marking. The ventral end of the rod should be at the level of ventral annulus. And then we have to mark the level. I'll be showing a short video also, and that will be the level and that will be the needle entry point. Now coming to the holding and advancement of the needle. So commonly we use it 18 gauge 20 centimeter needle. We have to see the direction of bevel. The direction of bevel matters because needle will move in the direction opposite to the needle. Suppose we have to go dorsal, so the needle bevel should be facing ventrally. And the direction of the bevel can be seen. There is a marking on the needle. There is a mark on the needle and we can correspond, because once it goes inside, we cannot see which side is the bevel. So we can see this mark and we can know which side is the bevel. And there will be marking on the needle. As we can see, there are various markings so that we can estimate how much depth we are going inside. And bevel lies on the same side of this marking. This is the how to hold the needle. So needle will go, I have already told that needle will go in the direction opposite to the bevel. So initially we have to keep the bevel ventrally so that it goes dorsally. It should not go too ventral to penetrate the peritoneum. Then we have to see marking on a needle to see which side of the bevel. For a right-handed person, we have to hold like this. That is push and withdraw with the right hand, and left hand should be used to manipulate the needle. Then in needle advancement, we have to go reach up to the first step in AP view. We have to touch the bony SAP in the first go. Then we have to, we should never cross the lateral pedicular line in AP view. Then we should shift to lateral view. And in lateral view, we will see that SAP. Then gradually we have to negotiate the SAP, reach the epidural space, and then again confirm in the lateral view that AP view that we have not crossed the medial pedicular line. So this is just a demonstration. In AP view, we have to reach this bony landmark, that is SAP. Then in lateral view, we will confirm that we are at the SAP level and we are not reached beyond that. And then gradually we will negotiate under the SAP, we will reach the epidural space, and then we can reach up to the annulus. And if required, we can go inside and do discography. And so this is the way to hold needle. It is okay to be more horizontal because we will be more dorsal only. We should not be more vertical. So the angle which sir told yesterday at 25-30, actually it should not be more vertical. Being more horizontal is okay. The same steps are shown here, the SAP in AP, then lateral view, and then negotiating inside the epidural space. This is a small video. So as we see, this is not a true AP view. Sometimes patients don't lie prone because of pain. So they will either tilt to one side. So you can turn the patient to make it straight. Now this is a true AP view. Midline marking, the line 1 marking. Then this is the marking of second line, disc level marking, but in which we can see it is going through the iliac crest. So we'll have to mark another line which will be going just above the iliac crest. So this will be a modification of second line, that this will be going above the iliac crest. Then lateral view. In lateral view, we should not be at the inferior end plate, and the anterior end of the rod should correspond with the anterior vertebral body. This is the way to hold while making lateral views, and we can pin roll between our thumb and index finger to make finer movements. This is the third line marking. Then marking the distance of entry. So this is first line, second line, third line, and that will be the needle entry point. Drawing a perpendicular line from the second line. We can use a hypodermic needle and local anesthesia. Then we should wait for 30 seconds and then proceed for the entry of needle. Then we are told that if the needle is facing ventrally, it will go dorsally. So the bevel should be facing ventrally. That is the first shoot we will be reaching at the SAP. Then confirm in the lateral. Take the needle slightly out around 1 centimeter and then go more laterally to negotiate below the SAP. Then again confirm in the lateral that we have crossed the SAP. So we have crossed the SAP, we have reached up to here, we have not crossed the posterior vertebral line. Then take a AP view to see we should not have crossed the medial pedicular line. So we are in the epidural space, then we can give dye. Dye should go freely. Then we can take a shoot to see. So we are in the epidural space, and after that we can deliver our drug, a local anesthesia with steroid, and there is splitting of the dye. So flushing of the dye after drug delivery also confirms the dye is more viscous, so it will not spread more, and the local anesthesia will spread further more than this because it is less viscous. Coming to the next facet block. So the presentation of facet block will be paramedian back pain, pain with increases on extension, pain increasing on climbing stairs, because it cannot be confirmed either on CT scan, MRI. No, nothing can confirm whether it is facetal block or not. It is either clinical diagnosis or a facet block, which can confirm that it is a facetal pain. So pain which increases on lateral bending, on lateral rotation. It rarely spreads to the lower limb up to knee, but usually it is localized paramedian back pain, which increases on extension. Similarly, cervical facet pain is suboccipital pain, shoulder pain, mid back pain. So initially it was intra-articular facet block. So the main facet can be facetal pain can be because of cartilage lining, overgrowth of bony spurs, fracture to the joint, or tear in the fibrous capsule of the joint. So intrafacetal block, we have to take needle inside the joint and there will be a giveaway sensation. Commonly used is medial branch block. So what is medial branch? It is a branch of dorsal ramus of the spinal nerve. So coming to the L4, L5 level facetal joint. So L4, L5 facet will be supplied by L3 and L4 nerve root. So this is L3 nerve root and this is L4 nerve root. So these two will be supplying the facet joint of L4, L5. 70% supply will be through the L4 nerve root and 30% through the L3 nerve root. So to commonly, we should see that for L4, L5 facet, we have to keep block near the L5 pedicle and L4 pedicle. So we have to block for this joint, we have to block this nerve and this nerve. So we have to go at the junction of SAP and transverse process for medial branch block. So at the junction of SAP and transverse process is the junction where we have to block the transverse nerve of a median branch nerve. And if there is 70 to 80% relief of the pain with injection and there is recurrence, then you can go for radiofrequency ablation, and which will give long-term benefit. So for radiofrequency ablation, it is 20 gauge rhizotomy needle with 1 centimeter exposed and the curved tip is curved. So the lesion does not occur through the tip of the rhizotomy probe, but it occurs through the, as we have seen, it is curved probe. So the lesion occurs through the length, exposed 1 centimeter length. So we have to go slightly oval, slightly oblique, and so that there will be an effective radius of around 2 millimeter will be ablated and the nerve will be ablated. Although the nerve goes along the medial border of the transverse process, but we have to go at the junction of SAP and transverse process, because there is a mammallo-accessory ligament which is represented by the white dots. So at the level of transverse process below the junction of SAP, the nerve will go under the accessory ligament and it will not be ablated. So we have to reach, as shown in the figure, the white part, only the junction of SAP and transverse process is to be ablated. So these are the oblique views and AP views. You can see in the AP views, we will be going oblique, and at the junction of SAP and transfer process, we will have to ablate the nerve. This is a similar bent spinal needle, and this is a point where we have to give block. In this case, annular tear was also there, so intradiscal block was also given, which shows the leakage of dye. This is the entry point of block for thoracic vertebra, that is the base of the superior articular process of that vertebra is the point for this median branch block. Coming to coccydynia, ganglion impar block, this is also very common. So if it is not relieved by medical management, we should go for ganglion impar block. And if the pain is coming again after giving ganglion impar block, we can proceed for radiofrequency ablation of ganglion impar. It is very simple procedure, and we all have seen so many patients of ganglion of coccydynia. For this, we require a hypodermic needle of 25 gauge and some bupivacaine with or without steroid in a 3 cc syringe and 2 cc contrast. Patient will lie prone, and you can use a pillow below the hip to just elevate it. And because we will going through the gluteal cleft, and First, we have to decide the entry in the midline with hypodermic needle and at the sacrococcygeal joint. Just give local there, wait for 30 seconds to 1 minute, and then go with the spinal needle. So in this way, there is also been described needle inside needle technique because we are going through the joint and it is going through the gluteal cleft. So it is better to go needle inside needle so that we don't have any infection in the joint space. This is the sacrococcygeal junction, and just beneath it will lie the ganglion impar. So we have to cross the joint and reach up to the ganglion impar. We can see just anterior to it is the rectum. So we should always give dye, and there will be a coma sign which we can see in this. So there will be localized collection of the dye, which will imply that we are at the ganglion and we are not inside the rectum. If we go inside the rectum, then the dye will go much higher and much lower. Then it will not affect. So this is described in literature as coma sign. This was a 13-year female with coccydynia. Conservative management failed. We can see bent coccyx, and this is the sacrococcygeal joint. So first we have to localize that we will be going through the sacrococcygeal joint. Sorry for the poor images. And this we can see the coma sign. So there was a perfect image. Then again we have to see a AP view to see whether we are in the midline or not. There are various other approaches also, like below the coccyx or paramedian approaches, but this is the best approach in the midline and excellent results. So thank you. Like here, doctor is practicing spine needles for his dart tournament. So similarly, you should also practice more and more blocks if you want to start your transforaminal endoscopy. Thank you.
Thank you, Dr. Mayuresh. Any questions from the audience?
I dilute it 50-50%, 1 ml plus 1 ml.
So any reason for that?
Even if you dilute it, you can increase the volume. There is, even if you go it without dilution, it works, but better you can dilute it.
Thank you.
So the advantage of diluting the dye is that suppose if you are at the wrong place and if you have a very dense dye, then your tip of the needles won't be seen. So in that situation, you'll have to wait, flush. So it is better to use very small amount of diluted dye for the first time. And then once you are sure that you are at a reasonable space, then you can increase the amount of dye or even the concentration.
Typically, usually you don't come across many cases of coccydynia routinely. So what are the typical
Failed
characteristics?
conservative management.
Okay. And imaging, what anything typically they show in coccydynia?
Like in this case, there was a bent coccyx. So although there was a relief, but if there is no bent coccyx and only inflammation of the ganglion impar, then those cases will give better result. And first we will have to give block, and if there is a temporary relief with the block and there is recurrent pain, then we can proceed for radiofrequency ablation. It has very good results.
Basically, it's a
Clinical diagnosis only. Thank you, sir.
Coccydynia is actually a radiculopathy of the tail. So the disc starts leaking and the nucleus pulposus material starts coming out and it spreads to the sacrococcygeal nerves. And that causes inflammation there and that leads to a pain, because in many cases you will find that pressing the coccyx is not very painful. Some people will have that also. And in my practice, I have found that getting these patients to do extension exercises also helps. Not in all cases, but in a few.
Yeah, but absolutely. There are a lot of reasons for coccydynia, but invariably you will get a history of some type of a fall, or you may also get history of prolonged sitting on hard surface. Also, if the ganglion impar block fails, then you have the digital manipulation technique. So you put your finger inside. So you put your finger inside the rectum and you correct the curvature. Also known to cause a lot of pain. So obviously we are not very sure of the exact cause of oxidine.
I have one question. Anybody else? This annular tear, at what stage you decide to give a block?
So in annular tear, we can give block because it is a leaking annulus and there is chemical neuritis.
So you don't try any conservative before that?
First, we should try conservative management.
How long?
Yes.
1 or 2
And if
weeks?
it is non-healing annular tear, we can go for block. And we prefer intradiscal block in that case. So we go inside the disc and give the block. So the drug will be delivered inside the disc and it will go along the track of annular tear and will reach up to the epidural space.
Thank you, Doctor.
So does it affect the pain? Like afterwards, patient may develop pain because we are putting in pressure into
So
an
in
already.
normal disc, we cannot insert anything. There will be a lot of resistance if there is no annular tear and if it is normal disc. So there will be a lot of resistance. You cannot push anything inside a normal disc if there is no annular tear. And if there is annular tear, you push inside, there will be a concordant pain. The same type of pain will replicate and it will confirm that this is the main pain generator. So there will be a concordant pain and the drug will go along the route. So it will give better pain management results.
So what do you inject intradiscally? I mean to say steroid with bupivacaine?
Steroid with bupivacaine.
Okay. Thank you.
Thank you, Dr.
And
Mayurish.
do you also use ozone?
No.
Okay.
Thank you, sir.
Thank you, Dr. Mayurish. With this, we'll proceed to our next session. I would like to invite Dr. Mabel Benson. She is neurosurgeon and fellow at Aditya Hospital, Jabalpur. She is going to talk on endoscopic lumbar discectomies for beginners.
Thank you, sir. Actually, the topic, there's a slight change. It's on a beginner's thoughts and experiences in lumbar endoscopic discectomies. This is more or less a story, and I hope that it will highlight the importance of having a teacher, and then also stimulates probably the young neurosurgeons present, including myself. So this will be the short outline. And by way of introduction, I'm Mabel, and I come from Ghana. It's a country found in the western part of Africa. This is a hospital I work with. It is the main referral center in Ghana. And probably when I go back, I would have to liaise with the military hospital, the Rich Hospital, and the University of Ghana Hospital. And this is basically because they have the very facilities for which I would require when I go back. So neurosurgery in Ghana, we have quite a very low neurosurgery to patient ratio back in Ghana. And despite expertise, we still have limited facilities when it comes to minimally invasive neurosurgery. But of course, we still have some bits of facilities in these areas. So personally, I like the art and science of neuroendoscopy. And because of that, I decided to follow on that path and search for a fellowship along that side. And that brought me to Jabalpur. And here I met my teachers, and they are always guiding us on the right path. They never hesitate to teach. When I came here, I was introduced to endoscopic spine surgery. Actually, in coming, I was more interested in brain keyhole and endoscopies. And here, I was introduced to endoscopic spine. My interest was definitely piqued. So that's actually brought me to talking about lumbar endoscopic surgeries at this program. So I am asked every day, am I learning anything? And I always give that answer. Yes, every day I learn a lot. And today, actually throughout these 3 days, I've come to really learn a lot more. in a short while, I'll probably use a case study to depict the very few things that I've come to pick up in lumbar endoscopic surgeries. So it's become clearer that endoscopic discectomy is the gold standard and probably not the next gold standard as we've seen during this course. And the main reason is that it's been shown to improve outcomes with respect to pain and disability scores, and overall patient outcome is also improved. Now I've come to learn that you need a good setup to be able to start this process of endoscopic surgeries and spine in this sense. And a dedicated staff who you can train is important. And having this helps with the flow of surgery and flow of activities when it comes. And of course, an administrative will is also very important in this sense. And we need our equipment that we work with. A good drill, a good RF cautery is very necessary. These are the general indications. I won't really roll on it. A typical case, I chose the L5S1K lumbar interlaminar discectomy because this is where I hope to start from. And I think that it will be a bit easier for me if I'm starting. We have a young female who presented with severe low back pain with lumbar radiculopathy and had a left EHL weakness. So this patient, when we imaged, we had L5S1 disc herniation with caudal migration more left-sided. And as per any case, a good positioning for surgery is very important. Here, we need to open up the interlaminar space. And in opening up the interlaminar space, breaking the bed becomes very important in this case, thereby helping with kyphosing of the lumbar spine, as shown in this image. This picture is to show a dedicated team checking and ensuring that the systems are working for surgery to occur. The surgery goes through a very small stab incision, usually just about 8 millimeter. And that is deep into the fascia and the dilators are introduced. This is actually being done by one of my fellow colleagues, Dr. Shawaib. Unfortunately, he couldn't join us for this program. And then once docking is done, it's cross-checked on image intensifier. This is the part I like about endoscopy, where the whole team is involved, no one is left out, and everyone participates during the surgery. So after docking, as has been shown, this is the initial image we see. And hemostasis becomes an important aspect in endoscopy in that we need a clear field to work with. For lumbar L5S1, as has been said, most of the time we don't require any bony decompression, as was this case. So right from the soft tissue dissection, you could see the, sorry. Right from soft tissue dissection, we could see the, sorry, the presentation has stopped. It looks like I have to go through this. Okay, so after tissue dissection, we could appreciate the ligamentum flavum, where we make a hole, an opening into it. I'll try and see if I'll be able to fast forward it. In this particular case, restarted. It's not moving forward. Yeah.
Meanwhile, I have one question, Dr. Ashish. When ligamentum flavum is very thick, that's how you make the first cut to hook it to make a.
So, sir, the system is designed in such a fashion that we cut the ligamentum flavum layer by layer. And then, because the tube is pushing on the flavum. So suppose if the flavum is like this, when we push the tube inside, so it stretches the flavum. So that is one way to avoid injury to the inside the neural structures.
If you find adhesion between dura and ligament.
Yes, I mean, findings would be the same, be it any approach. So I am forgetting, I think it was either Janmajay or Nidhi who showed that when you're doing any endoscopic procedure, if you have doubt, you separate the dura from the underlying structures. Same thing you do here as well. The advantage of an irrigation approach is that there is it has certain pressure. So it is pushing the dura and neural structures away from your instruments.
There are chances of dural injury.
Yes, yes, you can injure the dura. So that is why we go layer by layer. So initially, so what we teach is initially it will be yellow, then it will be light yellow, and then you'll have a bluish hue. When you get that bluish hue, you know that you're just at the inner layer. Then pierce with your static limb. Pierce and then cut.
Thank you, sir. So we're at the level of the opening into the ligamentum flavum, where sir has just described. As we made an opening, we could appreciate the extruded disc fragment here, which we had to take out first before we could proceed. And this fragment was directly compressing the nerve roots from behind. So once we're able to take this out, we could retract the nerve roots with a technique that has been shown over this period, where we rotate the beveled sheath or whichever direction is feasible, as is being shown here. And once that is done, it keeps the nerve root retracted such that we are able to move forward without much worry about the nerve root. But one thing too is that we need to regularly be able to relax the nerve root and then reapply the retraction as time goes on intermittently. So after this, we were able to do further decompression, and then eventually we get to see a nicely relaxed nerve root. And sometimes the inflamed nerve roots, you can actually see that the hue is improving. So then I asked myself that, yes, this is a very lovely surgery, but is it really what it is? So I took a look at the data available. So we did a preliminary assessment, a prospective study, where we took a look at 18 patients over the period of 6 months. And in the 6 months period, we realized that there's no gender predilection. Our average age was 48. And then we had more L45 lesions. And most of the patients had left-sided symptoms. Then we saw an improvement in preoperative visual analog scale scores. And that was what we evaluated actually. So then our average time to surgery was about a day and a half, and then average length of hospital stay was 3 days. And the length of stay was mainly increased by comorbid factors of the patient. All our approaches were interlaminar, and the average duration of time of surgery was about an hour and a half. And this was determined by whether we did an over-the-top decompression, as can be seen in this table. You could see quite a wide gap in time between ipsilateral approach only and then that of over-the-top approaches. And when we did a significant test to our pre-op VAS scores and post-op VAS scores, we realized that for back pain and limb pain, we had significant reduction in pain, and these showed statistical significance, which means that, yes, definitely, this is a fruitful endeavor that we should all try and utilize. So among the 18 patients, we had one dural tear, and this was managed conservatively. We didn't have to convert from the endoscopic approach. So the outlook definitely is an encouraging one for the beginner. And with this, we hope that we could have further collaborations, more conferences like this that would help us promote this. And then also fellowship at Advanced Neurocenter already is gaining global recognition. And I think that we as fellows, we try and promote this further. My take-home message is that we all require a teacher who would definitely take us from the light and guide us from the darkness and guide us into the light. Thank you.
Any questions from the audience?
So the dural tear that happened, what was the cause of it? What was being used when that dural tear happened? And what in these cases, I would like to ask Dr. Ashish, what is the most common cause of dural tear? Whether you are using a punch, annular cutter, when does that tear happen?
So in my hands, as I was discussing yesterday as well, that uh, limited drilling of the inferior articular facet was one of my biggest mistakes. So what was happening was at times I was retracting the theca and thinking that that's the root. And that is where the root sleeve used to get injured. Then as we gained experience, we realized that we have to see the root very clearly. And it is the root sleeve that generally gets injured. As far as the dura is concerned, I don't remember this specific what happened here right now, but you can injure the dura also, and that generally happens when you are using the through cut. The third place where you can injure is like for open, you're doing rongering and you may injure. And the fourth, obviously, when you're rotating the sleeve if you're not very careful. So those are the 3 or 4 things.
So this sleeve doesn't protect the dura?
Sir, it does protect, but what happens, sir, you're holding the sleeve with one hand and you're pushing it. At times, suppose a small piece gets stuck, then, and if you're not careful, then you can sort of injure it. But the good thing of this, the whole procedure is it's under irrigation. So suppose if you injure the root, when we are doing it under air or routine, we generally find that the root gushes out.
Okay.
And then, you know, we are there stuck 15 minutes, pushing the roots gradually in and then applying something here because of the generally the roots don't stick out immediately, which is an advantage.
So here you don't cut annulus at all, or just the breached annulus, you just go in
We
and
cut,
take
sir.
out.
I do absolutely the same thing that I would be doing with tubular. I even nowadays we have malleable forward disc punches also. So it goes through the sheath and then it goes anterior. So central. So central disc also you can remove. So straight, you cut the annulus, you open. Same, everything is similar.
Thank you. Thank you very much.
I would like to invite our next speaker, Dr. Himanshu Verma. He is neurosurgeon and fellow at Aditya Hospital, Jabalpur. Talking on neo techniques of pedicle screw fixation. Dr. Himanshu Verma.
Yes. Good morning, respected faculty and delegates. Today I'm going to talk about a new technique for pedicle screw fixation in lumbar spine. It's known as a cortical trajectory screw fixation in lumbar spine surgery, a review of existing literature. The pedicle screw fixation system has been accepted as a gold standard technique for spinal fusion because of its anchoring ability. The problems of screw has not been resolved, particularly in patients with osteoporotic bone. The fixation strength of pedicle screw in vertebral bone depends on 3 major factors: the vertebral geometry and bone quality, design and mechanical properties of the pedicle screw, and screw insertional techniques. Santoni, with his colleagues in 2009, introduced a new methodological screw insertional technique via cortical bone trajectory. As you can see in the pictures, the trajectory goes from medial to lateral in the transverse plane and caudal to cranial in the sagittal plane. It is a technique with a 4-point cortical bone contact. First in the dorsal lamina, second in the anterolateral pedicle, third in the inferior pedicle, and third in the anterolateral pedicle, and fourth in the lateral curvature of the vertebral end plate, making it giving it more purchase for the screw. As you can see in the picture, the cortical bone trajectory requires a less soft tissue dissection as compared to the traditional trajectory. Compared to pedicle screw fixation in the osteoporotic bone, CBT screw fixation had higher insertional torque, pull-out strength, fatigue resistance, and resistance to flexion and extension loading, resistance to lateral bending and axial rotation. The surgical technique. A midline incision is made at the affected level in a prone position. Paraspinal muscles dissected and retracted to the point, exposing the lateral borders of the pars interarticularis, preserving the supra and the interspinous ligaments, and avoiding the exposure of the fascial joints adjacent to fused segment. Spinous process partially dissected to achieve appropriate lateral angulation for the trajectory. The screw hole creation before the decompression procedure is preferred to achieve an ideal trajectory and avoid excessive bone resection. The junction of the center of the superior articular process and 1 mm inferior to the inferior border of the transverse process is used as an entry point. At 5 o'clock position of the left pedicle and 7 o'clock at the right pedicle. A selection of the lower entry point as much as possible is desired to avoid damage to the adjacent mobile segment. Spur formation and hypertrophy of the cranial facet joint can overhang to the pars interarticularis in cases with severe facet degeneration. Screw paths are made under true lateral fluoroscopic guidance. It is directed 25 to 30 degree cranially along the inferior border of the pedicle towards the posterior third of the posterior half of the superior end plate. Surgeon should prevent slippage towards the cranial side during the procedure. The starting point is at the laminar slope as it inclines cranially, and slippage may induce unintentional cranial fascial joint violation by the screws. A lateral angle of 10 degrees is sufficient to avoid risk of central neural injury. Starting points are located around the medial border of the pedicle. As you can see in the picture, is the ideal CBT starts at the caudal point of the pars interarticularis, follows a 25 to 30 degree cranially and 10 degree laterally directed path through the inferior border of the pedicle, and ends up the posterior third of the posterior half of the superior vertebral end plate. Special care should also be taken to check the trajectory and not breach the inferior medial border of the pedicle, close to the exiting nerve root. Our desirable screw path length is 30 to 35 mm, not penetrating the superior end plate or lateral medial wall of the vertebral body. This is the picture showing a comparison between the traditional pedicle screw fixation and the CBT technique, showing the screw is directed cranially and laterally compared to pedicle screw fixation. There is also a picture showing comparison between the soft tissue dissection between the traditional pedicle screw fixation and the CBT technique. Advantages: it is less invasive. The initial insertional point is medial on the pars interarticularis, so it requires a smaller initial incision, less muscle dissection and retraction, particularly pertinent in obese or morbidly obese patients. Reduction in intraoperative and postoperative blood loss, postoperative pain duration of the hospitalization, and an enhancement of the postoperative recovery. The safer profile for screw insertion as the trajectory is laterally directed in the transverse plane and caudocephalad in the sagittal plane. So the screw follows a path away from the nerve roots, dural sac, and the anterior vascular structures, which reduce risk of neurovascular damage. It may avoid injury to the medial branch nerves. Normally, the medial branch nerve is susceptible to injury by the traditional pedicle screw, especially one near the mammillary process. It reduces the risk of injury to the medial branch nerves may translate into reduced risk of postoperative radiculitis. It also can lower the facet joint violation rates. As the starting point is on the pars interarticularis side, that does not invade the superior facet joint. So significantly reduces the symptomatic adjacent segment disease generation and the radiological ASD. The indications are same, the posterior fixation during lumbar fixation as a TLIF. In decompressive lemnictomy, fusion is required. In osteoporosis and osteopenia in obese patient, and in symptomatic adjacent segment disease, or screw failure with pedicle screw fixation requiring revision surgery. Contraindications are relative contraindications are longer constructs of greater than 3 levels of multi-level scoliosis, or narrow or midline parts, or congenitally small pedicles. And absolute contraindications are congenital pars defect, lack of cortical bone at the parts, and iatrogenic pars fracture. The complications are same with the traditional pedicle screw fixation, like screw loosening, screw malpositioning, increased risk of pedicle fracture, inappropriate size screw diameter utilization, risk of upper nerve root injury, neurological deficit, infections, vascular injuries, CSF leak, wound adhesions, and urinary retention. My take-home message, it's a worthwhile, minimally invasive technique alternative to the traditional pedicle screw fixation when indicated. So the traditions are not bad, but they need to be evolved constantly. Thank you.
Thank you, Dr. Himanshu. Any questions from the audience?
Sorry. Sir, actually the indication is only limited to mainly to osteoporotic patients, but there's no enough data. There's a lack of data about. There's no need enough follow-up, so we still need to study further study.
I am into the C-arm. How will you know what is the entry point, or it is just based on the clinical what you are seeing intra-op?
So it is mainly intra finding. We have to just go inferior and medial.
Okay. So because what the conventional we have apart from intra picture, we have a C-arm confirmation also.
Yes.
That does not applies to your technique.
That does not apply.
Yeah.
But yeah, we can see in the radiographic also.
That is the screw trajectory, but the entry point part.
Entry point we have to do it intraoperatively.
See intraoperatively. Thank you.
Do you use navigation in such cases, or you are using only C-arm?
Only C-arm.
Oh, you're sure that it is not causing the lateral border of the vertebral body?
So we have to check it under radiographical in the C-arm.
It's likely in many cases that some threads may cross this lateral border of vertebral body.
Could happen, but we have to check it continuously on the C-arm.
Yeah, please.
The biggest advantage of this CBT technique is the medial pedicle wall is the strongest part of the pedicle. That bone is engaged in the screw pull-out strength is much higher than the conventional. Thank you.
Any other questions from the audience? Dr. Umesh, anything you want to add in this technique?
Especially if you have done a laminectomy already, and if the pars, if our T-leaf osteotomy that we do, if it has already extended some way into the pars, then probably the purchase at the level of the entry point will be good, and sometimes the lower border can get fractured. I think that is what we have seen in some cases, and the lateral border breach can easily be checked by probing. That is the best way to do it rather than radiologically. Sometimes radiologically also, because the lateral border of the vertebral body may not coincide with the tip of the screw. Sometimes it may breach anterior, this one. Of course, the breach is best detected by, and a small amount of breach is acceptable. It is not because it is just be in the plane between the psoas and the lateral border of the vertebral bone. So a small amount of bicortical purchase in these cases is acceptable. CBT has been biomechanically proven to be stronger than a pedicle screw. The other thing is we have to use a cortical screw.
Yes.
So you can't use a regular pedicle screw. So we should use a cortical screw for CBT. So which are very short pitch screws. Like unlike the cancellous screw, the regular pedicle screw that we use are cancellous screw.
Yes.
Now CBT is predominantly through and through a cortical bone. And that is why we have to use a cortical screw. If we use a cancellous screw with this technique, again, the screw purchase is not good.
Thank you.
Any other question? So we close this session. Thank you all the speakers and the audience. Thank you very much.
Thank you to the chairpersons and all the speakers for the wonderful last session of this wonderful teaching workshop. I would request the chairpersons to felicitate the speakers. I'll call one by one. Dr. Mayuresh Hinduja. I will ask Dr. Kachara to felicitate Dr. Mayuresh Hinduja. Dr. Mabel. Dr. Himanshu. Thank you, sir.
Next will be demonstration of UB by Dr. Dinesh Patel, sir. You can join on this side for demonstration. So there will be a demonstration of UB on the model for 20 minutes, and then there will be a validatory function in this hall only after the demonstration is over.
ये पीछे देन ओके everyone is here okay what is the problem in I think I can remove this echo hole. Hello. What is the problem in learning endoscopic surgery? Important issue is when I started my endoscopic journey in 2010 with Dr. Yadav sir. But there is a problem, money. Main issue is money for these type of techniques. Every technique requires 15, 20, 30, 40, 50 lakhs. Every technique. And main hindrance is that initially people are saying there is a long learning curve, long this, that, but I found that that is not the truth. Important issue is unavailability of instrument in any system, government, private, any system. When I bought cranial system in 2015-16, and I started left, right, everything with cranial system. And after 2 years, 2018, I attended large number of conferences related to transforaminal, then PSLD, followed by UB, and started transforaminal and spent about 20 lakhs. First, local system, followed by Karlsruhe system. Local systems are usually creates problem for the beginners. We usually initially spend less money and find difficulties. My advice is that initially you buy good systems, just like a car. When we use Maruti, then there is some problem. When you use but when you use Mercedes like things, then it's very comfortable. The same difference is there. People are saying we have no money, we have no funds, but initially any neurosurgeon, when he became neurosurgeon, first thing he do is buy a car. Second, he buy house. No, there is no need of buying car and house. You need to buy good instruments. Then you earn money and buy big house, big car. Really. So first go for the conferences. What you like? You want to learn transforaminal, you want to learn interlaminar or UV, anyone. Two conferences, then decide what you like. And finally, jump into that thing. Then attend one more conference and final decision is I like to spend on UB. Buy instruments from a big company, a good company, and then again go to the conference because until unless you have instruments, you attend conference, then start thinking, I will buy, that takes about 6-7 months or a year. Then your confidence goes. Then you think what we will do. So first buy the instruments and then go conference and come back and start the things. That is the best way. I done these things regularly and I experienced this. So don't make this type of mistakes. Let's start today with UB. This is a cranial end, this is caudal end. Where is the docking point or working space portal? This is spinous process and this is spinolaminar junction. Make skin incision just medial to the pedicle. Pedicle is here. Just medial to this and 0.2 to 3 mm lateral to spinous process, about 1 centimeter for working portal. And dock with the dilator, I think this one. Anything, no problem. Cut the skin and fascia along with that. 1 centimeter more than enough, 1.5 centimeter. And precisely dock at this place, spinolaminar junction. And then put serial dilators. Confirm with C-arm, it's not a big issue. When you are confirming with the C-arm, just tilt this, otherwise end on appearance. You will not able to find where it is. Just tilt this and put the serial dilators. I think, okay, there is this, then this. This 3 is more than sufficient. I usually put 3 dilators, not more than that. Then to and fro movements gently. So multifidus will separate. Then can you hold this? Obturator with sheath. बस ओके आजकल मुझे भी दिक्कत हो रही है This is the problem with local systems. This is very juggled. Otherwise, stars and all these things are very smooth. Okay, lock and making skin incision. Just remove this over cranial lamina at the spinolaminar junction, 0.5 mm away from the spinolaminar junction, and cut fascia 2 to 3 mm caudally, because your movement is like this. Otherwise, you will cut your scope will be here only. That is the issue. Then go smoothly and dock at this place. Okay, just we will do with single one. Can you hold this?
First, we'll create the instrument channel, then the.
Yeah. Otherwise, there is a bleeding and blood clots are there. That creates a problem. Then you will touch the tips of both the instruments and move 1 to 2 times. So the channel for the water irrigation will come out from this place. And remove this, put the scope. Locked, white balance and everything you should have to done, and then put it here. Clear with cautery probe, RF or plasma, what you have from this channel, and gradually coagulate the things. Some muscle fibers are there, fat and connective tissue, and see the edge of the lamina. Then start drilling from the spinolaminar junction from the base and come posteriorly. And after that, you see there is a gap in the ligamentum flavum. You can dissect with blunt dissector or with Carrison punch, what you like. And after removal of the ligamentum flavum, if there is a simple canal stenosis, go opposite side and same side. If there is a disc, remove the disc. We will make skin incision in this. You want this? Okay. एक बार इसका नीचे से देख लेते हैं कि कहाँ है. Anywhere. But in cervical region, you have to see the V of the upper lamina and lower lamina. That is the docking point. In thoracic region, then similar to spinolaminar junction, because there the laminas are almost juggled. There is a very fine space, very fine space. Just we will see that. नहीं पर स्पाइन के कहाँ पे वहीं पे डॉक करते हैं. Okay. This nails this almost nothing. Mark it pen. Okay. Mark the midline with C-arm. Okay. Mark the midline of the dead space. That will give you reference point. Then mark the spinolaminar junction to the medial border of pedicle in the caudal lamina, center of the disc, and about 2 to 3 centimeters cranially. Mark this at the spinolaminar junction. This is sufficient. This center of the disc space, that gives you the reference point. You are in the right place. Confirm AP lateral, you are at the right level. Most common mistakes people do in L5S1, most of the time. They land in L4 or they land in. And after once you have confirmed, need of C-arm is very minimal, very minimal. Then make skin incision, fascia, and same process. You have knife. Yeah. अच्छा इसी don't know. It will help. Knife कहाँ चलेंगे वो? नहीं Yes.
think you have been using horizontal incisions only, or for a beginner we should first go with vertical incision?
I never given horizontal. Because this gives movement of the instruments from here and there. Otherwise, your instrument will move this. Our working area is here to here.
Okay, that's the reason.
Initially, I have done with 2 ports, 3 ports, 4 ports, everything I have tried. Initially, there is a problem. You are not able to dog the things. You are not able to judge the things. Okay. On. Connect with the irrigating saline on the your side. Close this thing and don't know where it is. Okay. This is spinous process. Okay. I think we are on the opposite side, but not a big issue. Yeah. I think we have to move. Can you just get hands open? No, it's not a. Okay. Okay, fine. This is the lamina, spinolaminar junction. And no, this is more than. We are not. English, I just this way. That's the whole. I am trying to feel the tip of the scope. Okay, fine. This is spinolaminar junction. And start the drill. Start drilling at this junction. And there is usually 2 to 3 mm drilling is more than sufficient. More than sufficient.
That you use diamond burr or cutting?
Initially, you use diamond because there is chances of injury of the things. But when you are well versed with the things, you can use cutting burrs. I am using cutting burr. Depending your initially you use 0 degree, and then you can increase to 12 degree, 15 degree, 30 degree, 25 degree, and if you want go opposite side, you use 25, 30 degree. That give better perception of vision. Drilling start with this, and then after that ligamentum flavum you can detach from that. Ligamentum flavum detachment is also depends on if there is a disc at the axilla or shoulder. Do not remove more than half of the ligamentum flavum. Why we are injuring the things? And after that, everything is very clear in the view. If sometimes there is a bleeding, increase slight pressure of the irrigating saline. You can use for that, some people using irrigation pumps, but that is usually dangerous. You can use your BP instrument pump.
Increase the height of the.
Increase the height, but that never helps. Infusion bag भी आता है. Yeah. That is also available, but for a local, if you are not having those things, you can use with a BP cup. हाँ, needle वही. Yeah. Same thing. उसमें needle लगा के and then one person will pump, everything will goes well. And for you have plasma and RF, you can coagulate the things. That's not a big issue. Keep BP 90, 100, 90, 100. You can use your anesthetists do these things very well. And if there is a dural tear, most of the time it will heal. Most of the time, if minor. Don't worry about the things. Don't worry about the bleeding. You want to put a drain. I never use drains. Most of the people are using, but I never use, and there is never complication. Even 2 level, 3 level. You are a beginner, then always go for simple single level. Never go for 2 levels. There is a problem in 2 and 3 levels. Really. You're fatigued, bleeding from this place to that place. All these are, and skin marking and all the things. Because this level, you are perfectly. Then you have to adjust with other level. And one more important issue. If you are a right-handed, always start with the left-sided. Don't go right side. Don't go right side. Initially, 4, 5 cases, 10 cases, choose always left-sided pathology. Otherwise, your moral will down and you will stop the things. यार हमने शुरू किया था और काम नहीं कर पाए. हम काम हर बार ऐसे ही हो रहा है हमारे साथ और 2-3 बार आपसे अच्छा काम नहीं हुआ, then you will stop the things. Initially choose big disc cases. You feel happy. Public will appreciate around you. Important issue. अदरवाइज पब्लिक कहेगी हमें तो ओटी स्टाफ एंड जो भी आपके जूनियर्स कलीग्स हैं वो सब कहेंगे यार करने गया था एंडोस्कोपी एंड कुछ कर नहीं पाया. This is the main issue. If you are not doing well, because the first day you are making mahal in the OT and all the things. We are going to do endoscopic surgery. So everyone is interested for the new thing, how you will perform. These are the simple tricks. But UV as compared to transforaminal and interlaminar, easy, less expensive, more reliable. Really. I started with transforaminal, then some posterior pathologies I am not able to deal. I started interlaminar. Luckily, after 7-8 cases, my scope broken and I stopped the things. Then I went to learn UB. I see one case and came back and started the UB. You can do cervical, you can do thoracic, but first lumbar, 50-20 cases, and then switch over to cervical, then switch over to thoracic. Never go initially to thoracic or cervical. Paraplegia, quadriplegia. No, sir. We can use normal instruments. That no. Yeah. That is different. Yeah, yes, sir. Every transforaminal, interlaminar, UB, all are totally different. There is no combination permutation. But important in UB, sir, you can use your normal instruments. But you need RF, you need drill, either Medtronics. Most of the hospitals having Medtronics that can be used. Striker you can use, or any local Indian company you can use. Important issue is and plasma probe. That is also very costly. 25,000, 30,000, 5-6 cases you can operate. Drill, striker drill, single time use. And wear and tear of your scopes. For the beginners, I always advise use Chinese scope. Very good, very good, very good. That cost about 18 to 22,000, 25,000. If you use car stores or other big companies that costing 1.5 lakhs, 2 lakhs, 3 lakhs, never go for that. Initially people are paying for that 1.5 lakhs, 2 lakhs, but Ayushman created problem. One of my mentor of UB is charging 3.5 lakhs surgeon charge. Any question? And if you want to learn UB, after 2 to 3 months, you can come to Riva. Yeah. Everything 4.5, 10, 50. 15, if you RF, basic instruments, everything. With camera and all these. Okay. Depending on which company you are going to buy. Good company. 30, 35. Because camera system is, if you are going to stores and all these, that is costing 30, 35 lakhs. Good system. And 15 lakhs for these basic instruments of UB. 60, 70 lakhs. And if we are at drill, then it's again 20 lakhs more. Striker or Medtronics. Yeah, definitely. Yeah, yeah. Yeah, that is why I am asking if everyone is having, every hospital is having a camera system, then it costs 15 lakhs if basic thing we need for a UB. Least expensive, most reliable, most giving. Thank you. Thank you. Thank you. Thank you. ये बंद कर रहा तो तुम्हें थोड़ा सा सुधारने की जरूरत है मैं बनाऊं
So I have finally the pleasant, or I would say unpleasant, duty of bringing this conference to its finale. And I would be presenting my thanks for the conference. I would like to begin with my thanks to Dr. Alok sir, who's always been here. He sort of has been helping, guiding us through the last 1.5 decades. So we are extremely thankful to you, sir, for supporting us and helping in every which way. If you have liked the food in last 2-3 days, it's all because of his direct involvement in designing the menu. So we are extremely thankful to you, sir. I would like this opportunity to thank the seniors that I can see here, Darbari sir, Kachara sir. They have come forward on their own to assist us. Those seniors who are not here, Professor Yadav sir, Panse sir, Moda Saab. So a lot of seniors who have helped us. But I must truly tell you that in almost all the workshops that we have conducted, this has been the easiest for us. Though there were a lot of challenges, especially after the live surgery got cancelled. And the whole credit would go to Prashant, Amitesh, Sudhanshu, Mayuresh. They took up the mantle. They took up the challenge. Every job, right from audio visual management, hall management, taking care of delegates, designing the scientific program. Amitesh has even worked late nights because there were so many changes to be made. So my extreme thanks to the four of you for uh, standing with us. And I hope that we would be more than happy to work as a team for the future courses. I would also like to thank my fellows and other team members who have helped here, Mabel, Himanshu, but especially Reena, Anjali. They were in contact with every part of the conference, be the exhibition, stay, hotel, audiovisual, stationery, printing. And the biggest support we had was from Vinod and Prakash. They were the conference management, event management team. So we are extremely thankful for your help. You made our lives very easy. Especially, we were very happy with the live and virtual and the smooth transition between the two. There was no issues with that. And in the same line, I would like to present my thanks to Audiovisual, Dabbu and his team. I'm sorry, I don't know your name. So Vipin and all of you really helped us. It's smooth, and we are very happy that the Audiovisual, they have been with us for last 15 years, and it works very smooth. They know the in and out of the city, and it helps us a lot. I would like to next thank all my faculty members, the speakers, and the delegates. There's a lot of enthusiasm. We were very happy to see the enthusiasm amongst the senior and the junior delegates for this MIS, and we are very extremely hopeful that more and more would take up various MIS approaches. I know that it appears challenging in the initial stages, but once you've done 5-7 cases, everybody can perform it. And I'm very sure that you all will take back the various MIS approaches that you might have seen here. We are also available in case in future if you want to discuss anything. No conference is possible without the support of industry. When the live surgery got cancelled, I called up Jeon and they immediately said yes to the bone models. And so it all started from there. So we're extremely thankful to Ritesh and his team for bringing these models and helping us. Would like to specifically thank Sumit Pawar, who brought his teaching model on which you just saw Dinesh working. So he got it. These models are available at Amazon also. He has created it, and that could happen. And then stores and HRS navigation, they jumped in. Unfortunately, HRS navigation had trouble with their equipment during transit. So they were not able to demonstrate a lot here. However, stores took up the challenge. We had various sessions of VTOM and 3D endoscopy. So extremely helpful, thankful to them, as well as the pharma. They have supported the conference, sponsored. So we are extremely thankful. I would also take this opportunity to thank the members of Hotel Krishna for this elaborate arrangement and making our lives and stay comfortable. I would be extremely apologetic if I have missed a few names. Once again, we would like to invite you back to Jabalpur in the future. And we hope that we are able to conduct many more courses. We have already got some feedback forms, so that would help us to improve on this learning experience that we could create. Finally, once again, thanks to all of you. I would like to invite you for lunch now. Thank you.
Just a minute. In the end, I think Dr. Ashish Tandon deserves a standing ovation for his hard work. Thank you, Ashish.
Actually, I have not attended many spine conferences. Last NSSA meeting, it was in Indore in 2010, where Dr. Rakesh Gupta and Dr. Rege, they organized. That time I was part of the organizing team and could present. And this is the second meeting with spine meetings, very less commonly I attend, but I thoroughly enjoyed actually and learned a lot. And probably we'll go ahead and start the new thing like endoscopic spine surgery. So it's a good, I mean, stimulation, good, attending conferences and learning new things. So thanks a lot, Dr. Ashish and whole team, Dr. Alok sir, everybody. Thanks a lot.